Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. We shall start our next symposium, POCUS, Point of Care Ultrasound. Okay, ladies and gentlemen, I shall introduce our first speaker. I am honored to introduce Dr. Hidayah Shafie. She is a consultant emergency physician at the Emergency and Trauma Department of Hospital Kuala Lumpur. With a medical degree from National University of Malaysia in 2000, she pursued a master's in emergency medicine and later completed fellowships in emergency critical care and critical ultrasound with focus from 2016 to 2018. As a dedicated professional, Dr. Hidayah's role have ranged from house officer to specialist in various medical departments. Since May 2018, she has served as a consultant emergency physician at Hospital Kuala Lumpur. Dr. Hidayah actively contributes to medical education, holding instructor roles in national and international courses. She has a very impressive CV. Beyond her clinical commitments, Dr. Hidayah has made significant contributions to research, co-authoring the Dengue in Emergencies Manual and various publications. Her areas of interest include emergency critical care ultrasound, and toxicology. She is a member of esteemed medical societies, showcasing her commitment to advancing emergency medicine. Okay, with this, I invite Dr. Hidayah to deliver her lecture, Fluid Assessment with POCUS.
Okay, Assalamualaikum and a very good morning. So sorry for the technical delay. Thank you, Dr. Amir, for correcting everything, and thank you, Dr. Khairul, for that elaborated CV. Tak tahu kat mana ambil. Tak minta pun CV. Okay, I'm Dr. Hidayah. Okay. So first and foremost, I would like to thank the organizer for WISAC for inviting us today. So I'm going to Dr. Shah ada. Okay. So I'm going to deliver on how we assess fluid status by POCUS. Okay? And we know that fluid resuscitation is a cornerstone of management in medical therapy. Yeah? But following fluid infusion, there will be inconsistent increment of cardiac output. We know that 50% of our patients are fluid responsive, only 50%. And even though they are fluid responsive, many of them will develop fluid overload, and this is well documented actually. And because of physical assessment is not accurate enough to assess volume status, hence a POCUS can be the adjunct for this assessment because it provides us not only the hemodynamic parameter but also with the pathophysiology of shock itself. When we talk about fluid assessment, I personally would divide it into 4 components: fluid depletion, fluid tolerance, or fluid responsiveness, tolerance, and also access. And this would be my outline of presentation. So we will go one component by one component throughout this session. Okay. So let us follow the journey of this case, which has recently landed in our emergency department, who involved a 20-year-old man without any comorbidities. He was an aviation student, presented with fever, vomiting, and also diarrhea. Quite profuse diarrhea and also vomiting 10 times per day. There's no other systemic symptoms to suggest other infection. Clinically, he was dehydrated. Chest was normal, abdomen was soft, just a bit of tenderness at the epigastric region. And clearly he was in shock because severely tachycardic, BP was low, okay, has a bit of temperature and also pain score of 3. So we can assess fluid depletion in this patient or any other patient by these 4 components. The history, as you can see in this patient, he has losses and reduced intake. The physical assessment, biomarkers, for example, lactate and also hematocrit, and also point of care ultrasound. So how does a hypovolemia appear in POCUS? So this is a pattern recognition of hypovolemia in POCUS. What you can see, the chambers of the heart are small. It is underfilled, so small during diastole and also small during systole. Okay? And you can see at the parasternal short axis here, the ventricle almost what we call kissing or mid-papillary muscle hugging nowadays in the Twitter. They call it mid-pap hugging. And also the IVC totally collapsing. So these are the features of hypovolemia in POCUS, particularly in focused cardiac ultrasound. So the question now, should we proceed with assessment of fluid responsiveness at this moment of time? So who will proceed with fluid responsiveness? So the answer is not yet, because as coined by Manu Malbrain in 2020, fluid management can be divided into 4 phases, which is ROSE: resuscitation, optimization, stabilization, and also evacuation, and which every phase has its own objective and its own fluid balance. So during resuscitation, the first few minutes of patient's arrival, if the patient is hypovolemic, just give the fluid as per guideline, 30 mils per kg over 3 hours or for the first 1 hour. And once the patient is more stable, then we can fine tuning for the volume status during the optimization phase to support or to rescue the organ. The first phase is to rescue the patient's life, and the second phase is to rescue the organ. And this is the time we perform fluid responsiveness in order to give just nice fluid, but not as much as rendering the patient to have fluid overload. And subsequently in the ICU later on, fluid optimization, fluid stabilization, and also evacuation. So for this patient, we gave the patient 30 mils per kg of balanced crystalloid over 2 hours. And upon reassessment, the patient's clinical condition improved, hydration improved, JVP was not elevated, chest was still clear, abdomen soft, and there is a point of care test lactate improvement from 4.2 to 2.9. You can see the CCTVR are improving. However, the patient is still hypotensive with wide pulse pressure and also low diastole, MAP of 53 here, and less tachycardic. Okay. So the next question would be, would this patient benefit with more fluid? Would you give more fluid to this patient after 30 mils per kg? Okay. So this is the time that we perform fluid responsiveness, which is defined as, which is conducted after the initial fluid boluses to optimize the volume status, but to prevent complication of overload. Okay? With the principle of when we give preload challenge, there would be increment of cardiac output. And this is actually the dynamic assessment of the Starling curve, where actually the patient sits on his Starling curve. Okay, so by eyeballing, actually we can anticipate or we can predict fluid responsiveness. How do we do that? We can do POCUS, cardiac ultrasound, look at the parasternal short axis at the mid-papillary level. You can look at the diameter or the area of the LV during diastole. Okay, provided the contractility is good, because this is pertaining the normal Starling curve. Okay. If, let's say, the left ventricle area is small or the diameter is small, the chance is that if we give fluid, another fluid boluses, okay, the patient will be fluid responsive and improve the LV and diastolic area and or diameter further. Okay, so most probably this patient is sitting at the steep part of the Starling curve, which is the fluid responsive part. But if you do the POCUS, and you can see that the LV area is large already, with even though with good contractility, any preload or fluid bolus will most probably not be responsive or not be effective for this patient, because he is at the plateau part of the Starling curve. So this is the patient's POCUS at that moment, when the BP was low, after 30 mils per kg. You can see the contractility is good. The LV is well filled during diastole, because at the mid-papillary level, you can see during diastole, the LV dilate and comply well. Okay. And during systole, okay, there is a reduction of area by more than 30%. Okay. Contractility is also good. And you can see the IVC diameter improve. Okay. But the collapsibility is around 50%. Yeah. But better if we can do some quantification. We can actually measure the stroke volume surrogate, which is the LVOT-VTI, left ventricle outflow tract velocity time integral, using pulse wave Doppler. Okay, and here we can see the LVOT-VTI is 22. The normal range is 20 plus minus 3. So it is normal or a bit supranormal. And by simple deduction, using a very simple formula, we know blood pressure is equal to cardiac output times total peripheral resistance. Cardiac output equal to stroke volume times the heart rate, and we can measure the stroke volume surrogate. The LVOT area is fixed, so we can skip that actually. So by measuring LVOT-VTI, when the BP is low, LVOT-VTI just now is normal or supranormal, and the heart rate is around 110. So we know that this patient's problem is actually the total peripheral resistance. Patient is in vasoplegic shock. Okay. So what is the treatment for vasoplegia? It is vasopressor. Yeah, so this is the time the patients require vasopressor. So now you can see the difference between hypovolemia and also vasoplegia, which has been resuscitated. So you can see the small LV area during both diastole and systole because the preload is inadequate. But when we have given fluid, this is vasoplegia with enough volume. The vasoplegia can concomitantly have hypovolemia, right? Okay. So with enough volume, we can see the LV and diastole area is large, but the LV and systole area is small because the LV is contracting against a very low resistance. Hence, it ejects out the supranormal stroke volume. Okay, simple kan? Okay, right. So let us look at the patient again after 6 hours of arrival in emergency department with IVI NORAD ongoing and currently on IVI normal saline maintenance at 4 pint over 24 hours. Lungs still clear, JVP not elevated, abdomen soft, and the lactate improved or normalized. So the patient has produced enough blood pressure with good MAP. Okay. And the CCTV are normalized. So this patient later on was admitted to HDW. Okay. Right, in HDW, 24 hours later, the patient begins to complain breathlessness and a bit of epigastric pain. Hydration was still normal, JVP not elevated. Lungs begins to have bibasal crab, just very minimal crabs at the bases. Okay. CVS normal, abdomen soft, a bit of tenderness at the epigastric region, and the lactate elevated again. What do you expect? You expect the patient goes into shock again, right? Okay, so the CCTV are currently abnormal. So the patient has cold peripheries, BP dropped again despite on NORAD, not tachycardic, okay, and respiratory is 24. So when we do POCUS, what you can see now is a different pattern of, it's not hypovolemic and it's not vasoplegic. But because what you can see now, the LV is dilated during, dilated during diastole and not constricted during systole. So there is a problem of systole here. So most probably patient developed septic myocardium, and the real patient in our ED developed septic myocardium later on in the HDW. You can see the LV contractility is abnormal. The RV is still contracting well, and the IVC begins to dilate already. Right? So what do we do now? Okay, now you can see the progression of the patient from hypovolemic to vasoplegia with a good volume status and also septic myocardium with systolic dysfunction. The same patient. So now how do we address the hypotension, the newly developed hypotension? So we did perform LVOT-VTI to look at the stroke volume, and it is reduced. Okay, so the stroke volume reduced. And stroke volume, we know that is influenced by the preload, the contractility, and also the afterload. So how do we know that this patient would benefit with a little bit of fluid or not? Okay? So it is our job to find the small slope, okay, which the curve has been depressed down. Okay, with a small slope, So our job to do some preload challenge and to look for the stroke volume changes. So how do we do this? Okay, this is uh, the test of fluid responsiveness. Okay. So there are many methods using fluid challenge mimickers, or you can use methods which is based on heart and lung interaction. For example, stroke volume variation, IVC variation, or you can manipulate the ventilator to give some tidal volume challenge or and expiratory occlusion tests. So those are the preload challenge, and you can look at the stroke volume by POCUS or by SVV to see whether this patient is fluid responsive or not. Okay. So fluid challenge mimics. It is reliable in a spontaneously breathing patient, a patient with arrhythmia, and also in a low tidal volume ventilation strategy because it does not rely on the heart and lung interaction. However, it requires a direct measurement of cardiac output. So we cannot use the IABP, MAP, or pulse pressure to assess the uh, response. Okay? And it required a real-time assessment of cardiac output. So meaning that you have to stay there and you cannot lift up the probe if you use echo from the patient's skin and be with the patient throughout the fluid challenges process. Okay? Because the cardiac output will peak just minute after the fluid challenge. So, for example, I will go through a few methods. Okay, mini bolus, we can give 100 to 150 mils bolus using syringe. We cannot just put up the IV drip and then wait for it to finish, but we have to give with syringe actually. It is small volume, but it is able to predict the response of larger fluid infusion up to 500 cc. The cons is that this is irreversible. If you give the patient the fluid, then you cannot take it out if the patient develops fluid overload, right? And another challenge is that it requires excellent skill of echo because we need to detect 5% in a cardiac output changes because this is the fluid responsiveness in mini bolus. Okay, so what we can do, okay, we use real time and precise measurement of cardiac output. Okay, in my case, POCUS. Okay, and then we measure the cardiac output value, make sure patient is stable, and not in respiratory distress or not restless, and so on. We infuse 100 mils fluid. Okay, and then immediately measure the cardiac output. If the patient has 5% of change of cardiac output, then you can infuse the rest of the fluid up to 500 cc and then reassess the cardiac output for effectiveness of fluid resuscitation or fluid challenge. Okay. Another method is PLR, which will mobilize around 4 mils per kg of volume or 300 mils fluid from the pelvic region, splanchnic circulation, and also the lower limb. And this is good because it is reversible. It is so-called the self-transfusion. It's also highly sensitive and also specific. And the fluid responsiveness is larger. It is 10%, so it's easier to detect. Okay. But the cons is it is unsuitable for OT patient, especially surgical orthopedic patient with intracranial hypertension, and also intra-abdominal hypertension. So we have to do it correctly. The patient have to be started on proper position, 45 degree, to include the splanchnic circulation volume. Then we measure the cardiac output. Then we put up the patient, raise up the leg 45 degree without touching the patient, only manipulating the bed for 90 seconds. And then in real time, we reassess the cardiac output. And the increment of more than 10% is deemed fluid responsive, and you can give the rest of the fluid 500 cc and reassess the patient later on. Okay. Another method that use the heart and lung interaction is a stroke volume variation, the same LVOT-VTI, but you assess within a stipulated time. So the fluid responsive is a 15% changes of VTI max minus the VTI mean over the average VTI. I will show you the morphology afterwards. Okay? But it is unreliable if the patient is breathing spontaneously because it depends on the heart and lung interaction. Yeah? or patient with cardiac arrhythmia, patient with low tidal volume ventilation, 6 mils per kg, and so on. Okay. So it used the same principle as pulse pressure variation, whereby during inspiration, there will be reduce in preload by increase in LV preload and also reduce in LV afterload. Hence, the stroke volume is highest at the end of the inspiration and lowest at the end of the expiration. So what you can see in the point of care ultrasound or in the focus, okay, if the patient is fluid responsive, you can see the variation of velocity time integral. Okay, so these deems the patient is fluid responsive. And if you see on your right, okay, if the LVOT-VTI or the stroke volume is fixed and the same size, so most probably your patient is not fluid responsive. Okay? So the stroke volume variation actually can be correlated with the Starling curve. The higher the stroke volume variation, the more possibility of the patient is fluid responsive and he sits on the steep part of the Starling curve. IVC variation is another component or another method that we can use to look for fluid responsiveness, but this is the least reliable. That's why I don't do IVC scanning in my department or when I do round. I normally dismiss the IVC because I look at the heart and the lungs and most of the kidneys. Okay? Because it's not reliable, especially in spontaneous breathing patient. Even a sniff will cause IVC collapse. Okay? Especially in patient with respiratory distress. So don't do IVC. The only time that I do IVC if I encounter a pericardial effusion with RV collapse and the patient is also at the same time is hypovolemia. So I want to know whether the RV collapse is due to intrapericardial pressure or the intraventricular pressure. So if the IVC collapse in that situation, meaning that you can give fluid and reassess the patient. If it's dilated, most probably you are dealing with cardiac tamponade and you have to do pericardial synthesis. Okay? So IVC variation for spontaneously breathing patient, we look at the collapsibility is for more than 50%. For ventilated patient, we look at the distensibility of more than 15%. So this is an example of IVC collapsibility. On your left, there is a significant IVC variation. To start with, IVC is already small and it totally collapsed during inspiration. On the right side is absence of IVC variation from 2.6 to 2.4 diameter. So most probably the patient is not fluid responsive, but it is not reliable in so many situations. It's a lot of caveat for IVC. For intubated patient in your ICU, you can manipulate your ventilator as a preload challenge. What you can do, you can use an expiratory occlusion test. So you punch the button, expiratory hole for 15 seconds, and this will increase the preload into the RV and subsequently the pulmonary circulation and eventually into the LV. You need the real-time cardiac output assessment, and fluid responsiveness is deemed 5% change of the stroke volume. Okay. So, and this, even though it's very simple, it can predict the response up to 500 mils of fluid infusion. However, it is not reliable in a patient with a low tidal volume strategy at 6 mils per kg. But what you can do, okay, this is how we do it. Okay, precise cardiac output monitoring, pre and post test. Okay, and then if the patient is responsive, you can proceed with the fluid infusion. If your patient is being ventilated with 6 mils per kg, you can actually perform tidal volume challenge. You can increase the tidal volume transiently over 1 minute to 8 mils per kg. And you compare the variation of stroke volume during the 6 mils per kg and also 8 mils per kg. And any difference or delta of 2.5% is deemed fluid responsive. Yeah? So by increasing the tidal volume from 6 to 8, it will increase the intrathoracic pressure and also the magnitude of the heart and lung interaction. And these can unmask the fluid responsiveness in patient with low tidal volume ventilation strategy. Okay. So what about this patient? Let's go back to the patient. So how did we manage this patient with currently septic myocardium, cardiogenic shock, concomitant with septic shock? Okay. So for this patient, after PLR, the cardiac output remained the same. Okay, there is no improvement, so meaning that the patient is not fluid responsive. So what we did is, because the Starling curve now is being depressed due to the LV contractility abnormality. Okay, we have to improve the contractility by actually adding up the inotropy agent so that the contractility will improve. And then with the improvement of contractility, we can repeat the fluid responsive test, whether this patient now can be given fluid or not. Okay. So this patient, dobutamine was added in the patient. However, the fluid is being cut into half maintenance. Yeah. So the next component of fluid assessment is actually tolerance. Even though the patient is fluid responsive, they still have risk of having fluid overload. Okay? And this risk is highest, of course, if the patient is non-fluid responsive and fluid intolerance. Okay? And even though the patient is fluid responsive, but if, let's say, you are dealing with patient with ARDS, the chance is that fluid that we'll give will cause harm to the patient. Okay? So fluid intolerance is another component of fluid assessment, which is defined as the ability of the body to receive fluid without progressing to organ dysfunction. And we know that too much of fluid will cause hypotension and lead to organ dysfunction, but too much of fluid will cause venous congestion, reduce oxygen diffusion, and so on. And I go back to the previous slide. You can see the period or the window of euvolemia will be narrower in the presence of heart failure and also kidney failure, right? So, and each organ actually has its fluid tolerance, actually, and also its fluid overload complication. And POCUS can actually review or assess the fluid intolerance by looking at the heart, the lungs, and kidney at least. Yeah? Okay. And many article or many journal has recently emphasized that fluid management should be based on the combination of assessment of fluid responsiveness and also tolerance. Okay. And if you look at the heart tolerance can be divided into two parts, the left and also the right. Okay. The left heart intolerance or left ventricle intolerance we have seen in the systolic dysfunction, in the fluid responsive just now, okay. But equally important is the LV diastolic dysfunction, because the LV diastole function will receive the boluses of fluid. So we will see how diastolic dysfunction appear in POCUS, and also RV intolerance, so which is evidenced by pulmonary hypertension and also RV failure. Okay. So LV diastolic dysfunction can be assessed by performing transmitral inflow, looking at the blood flow into the LV during diastole, and hence we get the morphology and also severity of the diastolic function, and also by studying the LV tissue or ventricle myocardium by their movement away from the probe during diastole. And based on these two studies, the blood flow and the tissue movement, you can actually predict or measure the LV pressure and also the LA pressure. And APO is all about LA pressure. When the LA pressure is more than 15 or more than 18 millimeter mercury, so you will begin to see B lines or fluid overload in the lungs. If you don't know how to do diastolic dysfunction or diastolic function assessment, just scan the lung, because lung scan is easier than echo. So once the B lines appear at the bases, you have to be careful with the fluid infusion. Okay, so on your left, is a lung with A profile, which is dry lungs. On your right is a lung with B line, which is congested lungs. And this will happen once the LA pressure exceeds more than 18. Yeah. So looking at the right ventricle or right heart, so what are the evidence of right ventricle intolerance? So look at the evidence of pulmonary hypertension, and based on British Society of Echo, they suggest two features out of three structure: the RV or the IVS, the pulmonary artery, and also the RA and also IVC. These are the example of RV intolerance. You can see the RV is dilated, RA is also dilated. Okay, the IVS top right is being depressed by the high pressure of the RV. Okay, on the left bottom you can see the pulmonary artery is dilated. Okay, similar size with the aortic valve, and the IVC is dilated and fixed. Okay, you can also put some color to look for evidence of tricuspid regurgitation, and also to measure the TR max. If it is more than 2.6, so there's evidence of pulmonary hypertension. And also you can assess the contractility of the RV by doing TAPSE, tricuspid annulus planimetry systolic excursion. If it is by M mode, if it is less than 1.7, then the patient most probably in RV failure. And if we give fluid in this kind of patient, it will flood the peripheral circulation, the backflow, and then congest the kidney, the liver, and also the gut. Right? So these are the example. If you do a lung scan, lung ultrasound of the lung intolerance, if you see B lines, okay, well distributed bilaterally with bilateral pleural effusion, this is the features of heart failure. So this is one of the lung intolerance. And also the lung infection. If you see broad-based B lines, some subpleural consolidation, Schreck sign, and also hepatization of the lung tissue, this means the patient is fluid intolerant. Because why? In the lung infection, the inflammation, consolidation, the compressive vascular collapse, and also microthrombosis, this will lead to reduced blood flow capacity into the lungs, and also the vascular hypermobility will lead to interstitial edema. And with all the hypoxia and also hypercarbia, which lead to vasoconstriction of the pulmonary vasculature, and this will increase the fluid filtration and also congest the lungs. Okay, and I always make a point to scan the kidneys in all critically ill patients in our department to look at the kidney tolerance. You can see the size of the kidney, the echogenicity, and also the cortical thickness. On your left, clearly the patient is at the end stage of renal failure. Okay, almost no kidney there. It's very hyperechoic compared to the liver next door. And on your right, you can see there is hydronephrosis and thinning of the cortex, meaning that the kidney cannot tolerate so much of fluid. Okay. So for this patient, after 3 days of arrival, okay, in the ICU, he was comfortable on high flow nasal cannula, on low dose IVI NORAD, IVI dobutamine was weaned off, good hydration, but JVP is a bit elevated. Okay. Lungs has still bilateral cracks. All the vitals, all the numbers are good now. Okay. So what are the role of POCUS here? POCUS can actually give you some information whether this patient has fluid access or not by looking at venous congestion at the liver, kidney, and also the gut. Okay. What we can do, we can use Doppler ultrasound to look at the hepatic vein, portal vein, and also renal vein, which represent the congestion in the liver, gut, and also the kidneys respectively. And I believe that this has been practiced by many intensivists and also nephrologists to gauge or assess how much of fluid they need to extract out from this patient, for example, in hemodialysis or in the sequential ultrafiltration. Okay. So last but not least, yeah. So in assessing fluid status, especially in unstable hemodynamic patient, so look at the patient, whether the patient has any evidence of fluid depletion. If yes, okay, just give fluid and then come back and reassess the patient. If the patient is still unstable, perform fluid responsiveness to see whether there is any role of more fluid for this patient. If the patient is fluid responsive, but look at the evidence of fluid intolerance, assess the heart, assess the lungs, and also the kidney. If there is evidence of fluid intolerance, then you may need to support the patient and give conservative fluid therapy. If both fluid responsive and also fluid tolerance are not a problem, then you may give fluid. But in the presence of fluid unresponsive, but the patient is severely dehydrated. For example, the patient had complication of septic myocardium. In the presence of severe AGE, you have to support the heart and then repeat the fluid responsiveness. If the patient responds, then you deliver the fluid. If not, assess for the fluid excess. If there's evidence of fluid overload, support the patient and start diuresis or evacuation. Right? So you may perform fluid assessment at any time, but according to the fluid management phases, okay, during resuscitation, we look at the evidence of fluid depletion. Okay, once the patient more stable, we assess the patients for fluid responsiveness and tolerance. And also last but not least, once the patient has already out from the shock and stable, so we look at the evidence of fluid excess. Honestly, I do everything in one shot when the patients arrive or during resuscitation. So I normally will assess the fluid depletion. And after like 23 years of doing ultrasound, by eyeballing, I can actually predict whether this patient is fluid responsive or not, while at the same time assessing fluid tolerance. Yes, I'm that old, 23 years. Okay. So last but not least, POCUS not only can help you to assess fluid status, but it also convert a blind resuscitation into a visual one. With that, thank you.